Good evening, everyone. Welcome to Miracle of Living lecture. It's completely different than it's ever been, but I guarantee you it's going to be chock full of good information. We have some excellent panelists that are going to answer your questions, and you're going to leave from this evening feeling like you know something that you didn't know before. I'm Dr. Mary Beth Miller. I'm going to act as your moderator this evening. I'm going to start by introducing you to our distinguished panel. The first speaker is Dr. David Rand. He's the co-medical director of the Infection Control and the chair of the Special Pathogens Committee. Dr. David Rand is board certified in infectious disease and internal medicine. He graduated with honors from the Keck School of Medicine at the University of Southern California. He went on to complete his residency and fellowship at LAC USC Medical Center. He will be followed by Dr. John Kunesh. John Kunesh is a board-certified anatomic and clinical pathologist and has been practicing at Torrance Memorial since 1999. He did his residency and fellowship at UCSF after medical school at Stanford and undergraduate school at University of Arizona. Dr. Kunesh is the Clinical Laboratory Improvement Amendments Director of the Torrance Memorial Clinical Laboratory, Medical Director of the Torrance Memorial Donor Center and Transfusion Service, and a practicing surgical pathologist. He is very passionate for laboratory testing, the South Bay area, and fighting to get the right answers for patients in our community. Our last speaker will be Dr. Zachary Gray. Dr. Gray practices emergency medicine at Torrance Memorial Medical Center and is the Emergency Departmental Medical Director. He received his medical degree from USC Keck School of Medicine. So we'll start with Dr. Rand.
Thank you, Dr. Miller. Welcome, everyone. I'm glad you were able to join us tonight. And I'm going to kind of tell you about where we came from and where we got to and where we're going now in terms of COVID, more as an overview kind of thing. So hope I don't bore you too terribly much, but we'll start with the slide, and it really does start, let me back it up a bit. So it starts with the Infection Control Department, and we've had an Infection Control Department at Torrance Memorial for decades. And what we do is monitor and maintain policies and procedures that really prevent infections in hospitals. And the Infection Control Department was a logical place for us to start looking at policies and procedures and how we would handle certain different infectious diseases as they popped up. And from that, we developed the Special Pathogens Committee. We felt that that would be a better place for us to do our work and come up with the things that we needed to do to be prepared for emerging infectious diseases like Ebola, SARS, MERS, and other infectious diseases like that. This committee with the Infection Control Department allowed us, and what we had done in these departments, allowed us to be really prepared for what was coming with this COVID pandemic. So when we saw what was going on in the rest of the world, which was essentially in mid-February, late February, we realized we were going to have some sort of a response, and that we were going to have to become very prepared here at Torrance Memorial to meet what we felt was going to be an issue with COVID-19. So with that, we had to reach out to the rest of the hospital, and we developed what was called the COVID Command Center. And this was the heart and soul of how we prepared for our COVID response. It was a remarkable team. It was just such a pleasure to work with. We met every day and continue to meet now, and it's still a remarkable team to work with. It was made up of administration, emergency department, lab, nurses specifically, all you guys out there, gosh, thank God for you, and multiple other departments, and this is how we ended up preparing our response. And because of what we do here at Torrance Memorial and the progressive thinking of the people that were on the committee, we were able to develop a response that was, we feel, very, very effective when COVID finally arrived. So what we did initially is we began working with the ED department. And thank you, Dr. Gray, very, very much for all of your support and what you've done to help us through this pandemic. And we were able to reconfigure the emergency department, if you will, into a place where we could place COVID suspect or COVID positive patients and keep them separated from the rest of the ED. And we felt what that did is that allowed us to care for the COVID patients as well as continuing the care that we want to be able to give here at Torrance Memorial, which is stellar care in the emergency department. From there, we ended up having to decide where are we going to put our COVID patients? How are we going to care for them? And so we designated different floors within the hospital, and we used 7 Tower, 3 West, and 3 East ICU. And those were truly designated COVID floors. What that helped us to do was separate the patients, keep them apart from other patients who are non-COVID, and it really worked very, very well. We had nursing and respiratory therapy and phlebotomy all working in conjunction on those floors to help care for our COVID patients. We also had contingency plans if we needed to utilize other portions of the hospital as the need arose. This committee, I think the most important thing that I'd like to share about this is that this committee worked diligently to assure our access and supply of PPE, so much so that we never ran out. And did we have some scary times occasionally? Sure, we did, but we never ran out of PPE, and this was so that we could protect our patients and our nursing staff and the rest of the staff as best we possibly could. So it's real important to understand in that one that by doing what we did with our PPE and how we configured people donning and doffing, which is putting on and taking off PPE, we had zero transmissions of patients amongst themselves. We call that nosocomial transmission. So in other words, somebody in one room takes a disease and takes it to somebody in another. We had 0 transmissions that way. And only a handful of patient to staff exposures or transmissions. And those actually, when we looked into them, could all have been explained, or all were explained for a variety of reasons, but not failure of our PPE. And equally important is, although all of us at this table were extremely busy, we never came close to reaching the capacity of our hospital. So we were always prepared to take that next wave, that next surge, if we had to, and we're really well prepared for that. I'm very proud of the work that this committee has done in preparing our hospital for what ultimately happened. So next, COVID's here. So what we ended up doing, we admitted our first COVID patient in on March 10th, and we reached a peak in probably mid-April. And from that time, we've had a slow but steady decline in the admissions to the hospital for COVID-19. Right now, we have probably anywhere from 15 to 20 active patients, which has remained very steady over the last several weeks. In the beginning of all of this stuff, my partner and I, with much collaboration with Drs. Kunesh and a lot of other people, we pored over the initial data that was coming out of, gosh, anywhere, China, Italy, and we used all of this stuff to make our initial treatment paradigms. And the first treatments that we offered to people you've all heard of was hydroxychloroquine and azithromycin. We used that for quite a while, and this was combined with immune modulators. And we were early in the use of steroids too, and subsequently it's been vindicated, so we feel quite proud of that one as well. It subsequently has been refined into using remdesivir. I'm sure you all have heard about that. That's an antiviral agent that was initially designed for Ebola that we found to be effective for COVID-19. And with that, we use steroids, and we also now have the ability to use convalescent sera or plasma. I'm sure you've heard about that. That's been in the news an awful lot. And we are part of a large national study that allows us to be able to use that. We consider that to be standard of care, if you will, but you have to understand there really is no standard of care in treating COVID-19. It changes on a daily basis, and there's new data all the time, but we are keeping up with it as much as we possibly can, and we change things on the fly and sometimes on a daily basis. Also, in the beginning of the COVID pandemic, we had a difficult time with testing, and I know Dr. Kunesh is going to give you much more information about that, but we had to send our swabs out to an outside lab that sometimes took a week or more to come back. And as you can imagine, that was difficult to care for somebody. You had to keep them in isolation for a week, and trying to care for that patient was difficult. With Dr. Kunesh's help, thank you, we were able to obtain in-house testing. And these were much more rapid, and it truly was a game changer for us on the front lines as the clinicians treating these people, because we could very, very quickly say, this patient is COVID positive, this patient is COVID negative, get them the medications that they needed, or if they were negative, get them off of the COVID floor into another portion of the hospital. We really do believe our therapies have been effective. It's difficult to say because the studies just have not come out yet. They're slowly trickling out, and a lot of what we've done appear to have been vindicated in recent randomized clinical trials. As far as the person who we generally treated, who wound up in a hospital or in our ICU, these patients were usually 60 years of age or older with other medical illnesses or comorbidities. That was the general, and you've heard all of this in the news anyway. It's nothing new to you, I'm sure. But I do have to say that we treated enough young people as well. It wasn't, this is a non-discriminatory virus, and it was able to make young people sick as well. So that's how we treated COVID and got to the point of being able to treat COVID. And so what are we doing now? You know, what is Torrance Memorial and our COVID Command Center and Special Pathogens doing to look to the future? Well, we don't believe COVID is over. I don't think anybody does. And I think at this point, when you look at the nation, our state, and even LA County with increased testing and increased positive patients or increased positive cases, I think all of us can agree that COVID's not gone and that we're now seeing maybe some small spikes. I will have to emphasize this was expected with the country's reopening, but we know that we can do things like this rather safely. So what can you do to keep yourself safe? It's very simple, and you already know this. Wear a mask. There's a lot of controversy on masks. There really are. You can talk to one expert and then another, and you'll get a different opinion. I will tell you that my opinion is that they work. If they don't protect you from getting an illness, I'm very confident, and we do have studies that show that they will reduce droplet spread. If you are sick, it does a good job at protecting others from getting the illness that you might have. Social distancing, and this is another really important aspect. So if you can't wear a mask, 6 feet is about how far these droplets will go. And so if you maintain a distance of 6 feet or more, and I know you've heard a lot of different stuff that they can fly 30 feet and all of this other stuff, we know pretty well that it's a 6 foot margin, and if you keep yourself 6 feet away, you'll be safe. The last thing, again, is hand washing. And I know it sounds really silly, but when you wash your hands, you're able to get rid of physically the viral particle. We don't know exactly how much surfaces contribute to the actual being able to contract COVID-19, but even if it's a small percentage, washing your hands can help make that better. And I can't say enough that the tremendous efforts that we put forth to prepare for this pandemic and what Torrance Memorial itself was going to do for it is going to carry us further into the future. And we are prepared today that if a surge occurred or a spike occurred, that all of those processes that we have put in place that we're backing off a little bit on now can be reinstituted almost immediately, and we can get back to the state of readiness that we were at when this first started. And lastly, I want to give a super big thanks to everybody who has helped us in this journey and taking care of our patients and becoming prepared. The administration was remarkable. They really, whatever we asked for, they did their best to get. The emergency department has been also a remarkable partner. Dr. Gray and I have had many conversations over the past several months, and I can't express how much we appreciate it. Nurses, I really want you all to know how important you are to me, to my partner, Dr. Malofchak, because you guys have been the people taking care of the patients on a daily basis. You've been selfless, and I want to really give you all a shout out. Also would like to thank the foundation for all the food that they gave us. I know that we've got a joke in the intensive care unit that this is the COVID 30, somewhat like the freshman 7 or freshman 10. I think we've all gained weight during this time. And the community as well. All the cards and the food that you've brought us and the parade that you guys did for us, all remarkable. You guys are all heroes too. So with that, I'll turn the stage over to Dr. Kunesh and let him tell you all the details about testing.
So I'm going to interrupt here because usually we save our questions until the end, but we want to start taking questions in between the speakers. So my first question, and I'm going to just direct this to the whole panel, are colonoscopies and endoscopy procedures being done? Is it safe?
So colonoscopy and endoscopy procedures are being done. This was part of what we did when we opened up our elective surgery thing, or surgeries. We are pre-screening all elective procedures. So there's your physician, when they do the pre-op clearance and so on, will get a COVID screen that will be available to the practitioners prior to a surgical intervention. I believe the GI guys are doing something similar, but more importantly, we know PPE works, and so the GI folks are wearing PPE and are doing colonoscopies and endoscopies as we speak.
I would add one thing to that, and that you can also interpret that question the other way around. And if you're a patient that needs an endoscopy or colonoscopy, I think you can be confident that we are taking every precaution to try to prevent you from becoming ill. All employees, staff, physicians, everyone is being screened on a daily basis for fever. We're all wearing PPE. So I think, as Dr. Rand said, we have yet to have a transmission in the hospital or in the emergency department. And I think that you can be confident that if you come for an elective procedure, that you will be safe.
All right, a similar type question. What about cancer patients needing chemo coming to the hospital and all that, or ER?
I would answer that the same way, in that if you have a need for medical services, and your cancer doctor is advising you to obtain chemotherapy, the current coronavirus pandemic should not prevent you from taking your doctor's advice. And likewise, if you feel like you have a medical emergency, whether you have cancer and under chemotherapy or not, you should come to the hospital emergency department. We're doing everything we can to keep everybody safe and take the same good care of people that we always have.
All right, I'm going to take a moment to apologize for some sound difficulties that we're having. I think we're getting it fixed, so hang in there with us. So now I'll turn it over to Dr. Kunesh.
Okay, David, thank you so much for your great talk there, and the kind words that you gave to the lab. I know that month from mid-March to mid-April, before we got those first BD reagent kits in, were some of the most difficult times that we've had in the lab. I mean, working every day to try some way to get to get through these supply chain issues that we had, and be able to at least move the patients along. What I decided to do is, testing is such a big area, and with only 10 or 15 minutes, is to take the one issue right now, which we're getting the most questions and the most frustrations from people in the community, and that are the issue of asymptomatic screening and what's going on in terms of our testing. So this is a very busy slide, so ignore the slide for now. I'm just going to start off by saying, in general, there are two main categories of tests for SARS-CoV-2. You have your viral tests, which are also called your molecular tests. These are PCR, there's isothermal amplification, there's antigen tests, there's next-generation sequencing. They're all testing for active viral infection. That's what I'm going to be talking about here. There's a whole different category of tests called serology tests, which are tests of previous infection. And I'm not going to be talking about them here, but I can certainly address those in questions. Again, it's such a big area. So I'm focusing on asymptomatic screening right now. And when we look at this topic, the first thing we have to decide is, are our tests actually good enough to do what we're asking them to do? Are they good enough to go out in the sea of negative people and pick out the people, the rare people who are positive and reliably? The first place we go to look to see if that's even possible is we go into their emergency use authorizations. Now, these are the very abbreviated FDA approval that these tests get. Basically, these approvals are, can you identify the virus? Are you identifying only the virus and nothing else? And then you're good to go. I mean, it was literally that simple in the beginning because we needed these tests out so quickly, and it is very different from a full FDA approval, which can take years. When you look at these tests, one thing that's in these EUAs is the limit of detection. And that is what is called the analytic sensitivity, which is very simply dilutions of either inactivated virus or viral particles. And it is the most dilute specimen in which you're still detecting 19 out of 20 positive. That's your limit of detection. That is the sensitivity that we get from these EUAs. So you think, okay, we just pick the one with the best limit of detection, LOD. We like these acronyms to make us sound smart. It doesn't quite work that way because these are all done in different ways. And in the real world, as we gain experience with these tests, there's not necessarily a correlate with the ones with the best limits of detection in their validation. So on the left, that's just a reference if anybody wants to go to it. It's a nice review of most of the EUAs that were given for these molecular tests and what their limited detections are and how they were determined. What I want everyone to focus on now is that middle graph, because I think this gives a good sense of what we're trying to assess in terms of clinical sensitivity, which is, are you able to detect real people who are infected? This can vary because at each day from exposure, you have a different viral load in different parts of your body, and that can determine whether your test is going to be positive. There is also incredible inter-individual variation between how much virus is in, say, even just the nose or the throat. So these can also determine what your clinical sensitivity is. A lot more complicated than just a mere laboratory analytical sensitivity. But that middle graph is a mathematical model which combines many different studies. And so the absolute numbers aren't as important, but I think it gives a good feeling for what these tests can do. What it is your chance of having a negative test for every day post-exposure of someone who is truly infected. On the top, that's a 100% chance of being a negative test. And on the left, that is day 0. You are at Trader Joe's, you got sneezed on, you're now infected, right? So day 1, day 2, day 3, your test is negative, okay? You are infected, but your test is negative, right? There's just not enough virus there to be discriminated against nothing, right, reliably. So according to this model, day 4, you start maybe becoming positive. Most people think now day 4 with some of our better tests is actually a pretty good day to get tested, if you think. But their model, day 4, maybe yes, maybe no. That's going to depend on whether you're a high viral load person or a low viral load person, right? Maybe yes, maybe no. Day 5, that's that vertical line. That's when symptoms typically start, right? Then you got day 6, day 7, day 8, viral load peaks, right? Your chances of having a positive test is the best. And then you have this long tail where many people just continue to be positive for weeks. And Turns out those people probably aren't infectious. Infection typically lasts 14 days, 10 days post-symptoms. Are these false positives? No. They're real positives. They're doing what they're doing. They're detecting viral RNA. It's just, it's not replicating virus. It's maybe fragments of virus or bits of virus. So clinically insignificant, but still a positive test. So if you look at this graph now, if everyone were symptomatic, okay, and you had no asymptomatic transmission, would testing asymptomatic people be worthwhile? And the answer is no, because at day 1 and day 2 and day 3, your test is negative no matter what. Testing would only get you maybe a day, whereas if you just focused on better testing for fever, headache, symptoms, you could probably make up that day, and it wouldn't be worth doing all that testing. The problem and the conundrum is with this asymptomatic population, because if you take away that line, now maybe there's a 10-day block where you could maybe detect people who could be transmitting, and if you take them out of the population, they wouldn't be transmitting. So that is the reason that there's a push by some to do all of this asymptomatic testing. The graphs on the right, they're great. Look up the reference. I don't have time to talk about it, but it's basically, are you infectious after 10 or 14 days, and how much virus is in each individual's nose or throat. So say you decide, yeah, I have a business, I have employees, they'll feel safer if we want to do testing. Where would I go to get recommendations? Well, the first place people usually go is the CDC, and this is directly from their webpage. So just a couple of weeks ago, the CDC posted on their webpage that you could consider testing employees in the workplace, and one thing you could do is test everyone there once a week. Of course, you have to have a plan for what to do if people are positive. In reality, some places are actually doing a version of this already. We've been getting a lot of requests and frustrations from people who need tests for certain reasons. Kids need to go to summer camp. They can't go until they get a test. Kids are going off to college. They can't go unless they get a test. People who work in daycare facilities can't go to work unless they get a test. This is, in reality, they're having a hard time getting these tests. You want to say, oh, there's a booth, COVID testing, test me, I'm good, I need to go to work. Those aren't out there. What you have to do is go to a clinic, go to your doctor, go to a government site where you have to fill in a clinical symptoms form and hopefully get an appointment, which can be hard to get. So why this hassle? Why is there this disconnect? And that can boil down to these regulations again. And this is from the FDA's Frequently Asked Questions site. And what it boils down to is how these tests are approved. Right now, all of these tests have been authorized only for use in individuals suspected of having COVID-19 by their healthcare providers. Okay? None of these, 0, are actually approved for asymptomatic testing. How have people gotten around this? It's if you break it down into 2 parts, the virus is all over the planet. You can have asymptomatic people. So just being a human on planet Earth can make you be suspected of having COVID-19. And the other aspect is the healthcare provider. That's why you need to go to a clinic or to get one of these tests. So the FDA, realizing that the CDC came out with these recommendations and realizing that there are actually no tests that are actually have an indication for use to fulfill the CDC's recommendations, addressed this just last Monday and said that, okay, we're going to give a way for these test manufacturers and developers to validate their tests for asymptomatic testing. And they were actually very, very helpful, because what they did was created and this was created a few weeks ago actually, a test of the test, which is sort of a standardized test that you can give your test to prove that is a highly sensitive test. Because again, if you're going to do this kind of screening, you need the best test there is. Because you have this window period where you're going to miss people no matter what. And so if you pass that, then they have to go out into the community and prove that they can find asymptomatic individuals in their actual patient pool. If you can do that, then you'll be approved for asymptomatic screening. So this could have implications in the workplace, schools, universities who want to incorporate this. But the other problem with this is who's going to pay for all this testing if this is going to want to be done? Because it's not going to be the healthcare, it's not going to be the insurers, because the insurance companies, this isn't medical, this is employee screening. So these costs will be put on the businesses or the individuals. The EEOC says it's okay to make an employee get a test before coming into work. So our individuals, our businesses, our schools who want to do this may be bearing the financial burdens of this unless the government steps in with some help. So will your workplace end up looking like this? Okay, are you going to come into the office like this? Probably not, because most of these tests are now approved for self-collection. It's going to be these little nasal swabs that look like Q-tips that you can stick in each nostril. You stick in the thing, you put it in the bag, you put it in the box, right? Sometimes saliva is getting to be more and more of a validated specimen where you spit into a cup or a tube until you fill a line, and then you put it in the thing and you hand the specimen in. I saw UCSD has a system where they have an app where you register for the app. The app has a barcode reader. You pick up a test kit. You zap your test kit. That way you're linked to that test. You do your self-collection. You drop it into the box. So this may be a future for some, but there's a lot of problems with this and a lot of issues. So it's not a simple solution. So anyway, that's one thing that we're dealing with. So I carved that one out.
All right, so we're going to do a couple more questions, and I know you said that you weren't going to touch on antibody tests, but I think it's worth answering this question.
Oh, sure.
My doctor said that the antibody test isn't conclusive. If that is the case, why are they giving the test?
Yeah, that's a good reason, because it's amazing to me that these antibody tests are even a thing. And it was amazing to the FDA that they're really a thing, because they thought they were going to be such not a thing that they chose to not even regulate them in the beginning. And they thought only epidemiologists are going to want to do them, so we're not even going to regulate them. But so by deciding to not regulate them, that created a market for this mass influx of all these tests and the promotion of these tests, that they were going to give immunity passports or immunity licenses, and they were going to prove that you couldn't get the COVID-19. And governments bought into this, bought hundreds of thousands of these, and it turned into a big fail. There are very good antibody tests out there, but there's still, with none of them, there is no correlate with reinfection risk. Okay, we don't know. Even if you have antibodies, there is no correlate with immunity or reinfection risk. So for most people, they want to know, can they get it again? The antibody test is absolutely meaningless. There are some very certain circumstances where it can be useful. If you really are interested in finding out if someone has been previously infected, for example, this multi-system inflammatory syndrome that these kids get, a lot of times they're post-viral stage and antibody tests can be useful. In those very targeted situations, knowing that someone has been exposed or has had it can be helpful in making the diagnosis. But in general, there really hasn't been a use for them. Although on the large throughput analyzers, there are some very good tests now that are highly specific. The lateral flow typically aren't them. We were just talking earlier that there were close to 60 of these lateral flows on the original page when these all came out. People called it the Wild West because no one knew how good any of them were. Well, in late April, early May, the new sheriff came in and the FDA made them prove that they were any good. And now 50 of those are on the do not use list, are completely off the market. And if anyone has any of these tests, they need to throw them away because they give wrong information. There's only 6 left of the lateral flow. Those are the little pregnancy type tests. The large analyzer, the chemiluminescent, the ELISA, some of those are very good. But still, they don't give you useful information right now. Maybe when we have a vaccine, there may be a correlate there with specific tests for vaccine effectiveness. In that case, it might be useful. But right now, not useful.
Will rapid testing be available in the outpatient setting within Torrance Memorial anytime soon?
Okay, so there's 2 types of rapid testing. There's rapid molecular testing. And right now, in the outpatient setting, we do not have the supply for reliable rapid molecular testing in the outpatient setting. We are using all of our reliable rapid tests for emergency room, for very critical reasons. So we are keeping very tight control of our supply there. For rapid antibody testing, such as those lateral flow, I have no reason to ever bring any of those in.
All right, we'll turn the floor over to Dr. Gray.
Good evening, everybody. So I want to talk a little bit about what to expect if you come to the hospital emergency department during coronavirus season, I guess, and both in terms of if you feel like you might have coronavirus or if you feel like you're having some other type of medical problem. So first, with respect to coronavirus, the most important thing to recognize is that most people who come down with this infection are actually going to recover without any specific treatment and don't require hospitalization. That is still the majority of people that we are seeing in the hospital emergency room. And that's a surprise to many people. When you come in and you're thought to be a suspect case with possible coronavirus or some other infectious syndrome that we can't immediately distinguish from coronavirus, you will be triaged to a specific part of the emergency department, like Dr. Rand alluded to, where everyone there is a suspect case. So we are trying to figure out whether every individual there possibly has coronavirus or not, and we're trying to keep them away from all of the other people that are coming to the emergency room for their heart attacks or strokes or other infections, any other medical emergency, broken bone, severe allergic reaction, all the things we typically take care of as well. When you come, if you are mildly to moderately ill but don't require extra oxygen or any other kind of supportive care, you will very likely have some testing done, most typically at least a chest x-ray to evaluate whether or not there is significant involvement of your lungs with the infection. That is for young, healthy people, aside from vital signs and a careful physical exam, that's going to be the limit of the testing in most cases. If your vital signs are okay and you're well hydrated and you don't need extra oxygen and your chest x-ray is unremarkable, you're very likely to go home with instructions about how to take care of yourself, how to prevent the spread of infection, and return precautions, what we call return precautions, instructions about when to come back to the hospital under what circumstances. On the other hand, if you come in and you are severely ill with COVID-19, you will likely get an additional battery of tests in the emergency department, including blood work, sometimes a CT scan, because chest x-rays can be difficult to interpret, and there are other problems that coexist with this infection that have specific treatments, blood clotting problems, for instance, where a CT scan might help us above and beyond just chest x-rays. And like I said, if you have a significant need for supportive care, hydration, or extra oxygen, and in the extreme support of your breathing with mechanical ventilation, you will be hospitalized. And under those circumstances, as Dr. Rand was saying, we have some therapies that we use that in this subset of people with coronavirus seem to offer benefit, including steroids and a whole host of other immunologic modalities and antiviral medications. None of these medicines have any impact on mildly ill people that are well enough to go home, and so we don't use them on people that are well enough to go home. Many people wonder whether or not they're going to get a viral test when they come to the hospital emergency department. And as of now, if you're well enough to go home, the answer to that question at Torrance Memorial is no. We are really cautiously guarding our supply of tests so that we can use them on people that are severely ill and try to discriminate who needs what. And we unfortunately don't have enough testing capacity at present to be able to routinely test people that are well enough to go home. That may change in the near future, but for now that remains the case. We do try our best to get you pointed in the correct direction to obtain outpatient testing. Sometimes that involves coordinating with your health plan or your primary care physician or your health network, but it's sort of different for every person because of the patchwork way that our healthcare system is set up, even here at Torrance Memorial. So that's what to expect if you think you might have coronavirus. But I think even more importantly, from my point of view tonight, is I think one of the most concerning things we've seen in the emergency department over the last 3 to 4 months is not as many people coming to the hospital for the same type of routine emergencies, if there is such a thing, that we're used to taking care of. Things like heart attack and stroke, other severe infections, people with bleeding problems or cancer, things that where they need emergency treatment or stabilization and they have been afraid of coming because of the risk of getting sick coming to the emergency department. I think we have learned over the last several months that we are doing a very good job of keeping people from contracting COVID-19 or coronavirus by coming to the hospital. We have yet to see a case where we think one patient has given it to another. And we've had just a handful of cases where staff have become infected and they have been rapidly identified and have not worked until they have recovered. We see an excess of death in our mortality statistics across the country that isn't directly explained by coronavirus infection. And I think many of us believe it has to do with delayed care for heart attack and stroke and other emergencies. So I can't emphasize this enough. Your risk of harm or death by delaying a potential emergency that is not COVID related is much, much higher than your risk of becoming sick with coronavirus by virtue of coming to the hospital to get taken care of. That's, if you remember nothing else about what I've said, that's the most important thing. Let's see. Yeah, this basically summarizes that as well. So don't stay home if you're sick. That's the bottom line. Now, we don't want people with mild symptoms coming to the hospital. We would prefer that you contact your regular doctor. If you're having a new but not emergent medical problem, your regular doctor is the person to contact. Likewise, if you have mild flu-like symptoms or mild cold symptoms that could be compatible with a coronavirus infection, you do not need to come to the hospital. If you do, we will take care of you, but you can be managed as an outpatient by your regular doctor. But if you think you're having a medical emergency, we would want you to call 911 or come directly to the hospital by whatever the safest means is. Again, you're at a much greater risk of something bad happening if you delay your emergency care. There are many emergencies that have very time-sensitive treatments that we just can't treat if you come to the hospital after your symptoms have been present for too long. And probably the best example of that is stroke. We have very good treatments for stroke that save a lot of lives and prevent a lot of disability, but our most successful treatment to date is not an option if you have had your symptoms for more than 4.5 hours by the time you get here. So just keep that in mind. Any questions?
All right, so I'm going to do my little pitch for primary care. We know that across the country, probably across the world, people have deferred getting mammograms and getting immunizations and doing other things that they need to be doing to make sure that they're in a good state of health. And it's just very important to recognize that that should not be let go. The clinics around the country are doing very good to limit how many patients are in the waiting room, how many patients are in the clinic. We're doing telehealth. where we can visit with you on the phone or on the computer, so you don't even have to come in. If you need to be seen, if we need to do a chest x-ray, we make it very safe for you when you come into the clinic. So it's just an important part of ongoing health care, not to neglect other things that might make you sicker in the long run because you're afraid of corona. And that's one thing I want to really stress, because I think the media has maybe put a lot of fear into the hearts of many of us that corona is a death sentence. And corona does need to be taken seriously. There's no doubt that there's a population of people that are at high risk. But for most people, it's going to be mild symptoms that you can treat at home and you'll get better, and you do have to be careful about exposing our high-risk folks. But you should not be scared beyond belief that if you get corona, you're going to be gone. So be aware of that, and the clinic is an appropriate place where we can do telehealth and talk to you about your symptoms and be able to reassure you about what you need to do. So now I'm going to cover a few more questions. If you've previously had COVID with mild symptoms and then you get it again, will you have mild symptoms or can you get more severe symptoms?
That's a good question, and I think the heart of it is, if you've had coronavirus previously, can you get it again? As far as COVID-19 goes, or SARS-CoV-2, we just don't know. It's not been around long enough and has not been studied enough for us to know for certain. If you look at the routine community circulating coronaviruses that cause the, quote, common cold, which actually can become quite serious in certain individuals, those with asthma and underlying lung disease specifically, you can get infected with other serovars. So you get one doesn't mean you're necessarily going to be able to fight off the next one. And right now there are 4 circulating ones that we can identify anyway through some of the molecular testing that Dr. Kunesh had talked about. But for COVID-19, we just don't know.
All right. Is the hospital ready for a large number of COVID patients, and how will the hospital handle regular emergencies?
I would say that we are ready for a much larger number of coronavirus or COVID patients than we are seeing currently. Obviously, if you make that number large enough, then we are not ready, but we are as ready as we can be. And we are doing the best we can to keep these 2 portions of the hospital emergency department running in parallel so that we can take care of our typical emergency department patients alongside but isolated from our potential or suspect COVID-19 cases. And so I think we have a robust capacity, and if anything, our volumes of patients are lower than they have been historically. So I think if we had a recurrence of the volume we saw in March and April, we would easily be able to handle that, and I think that we still retained capacity to scale up from there. So I'm optimistic that we can handle what comes.
What is Torrance Memorial specifically doing to keep patients safe?
I think that comes down to what the measures that we've taken on visitor restriction. I know that's a difficult topic for people to deal with at this point. It's god-awful to have a loved one in the hospital and nobody can come and visit them, but that's a very important portion of what we do to keep our patients safe. And we're continuing to do that. We are talking on a weekly basis as to whether or not that may be relaxed. As of now, it's not going to be, and with the increase in cases, that may take a little bit longer for us to relax that. So as far as our healthcare providers go, they're being temperature screened on a daily basis when they come in. And then those folks that are caring for COVID patients on any one of the COVID floors, the PPE that I discussed before, the masks, the gowns, the face shields, which are utilized every time one goes into a room, I think has made for an incredibly safe environment here at Torrance Memorial. And as I discussed earlier, Dr. Gray discussed, we truly had 0 in-hospital transmissions from patient to patient. I can say with as much confidence as I possibly can that coming to Torrance Memorial for your care is as safe as you could possibly hope for.
So this will be another question for Dr. Kunesh. He's kind of covered it, but I think I'll give him a chance to reiterate. Can you get tested for antibodies months after you've had COVID? Will it still show up?
That's a good question. Typically, I think the answer would be yes. But some people never develop an antibody response, and some people it might go away. So I think it's really unclear at this point. We don't know very much about the immunity to this because it's only been around for 6 months. So months after, we're 6 months into this. We don't know what months after even looks like right now. So I think that's a question that's going to be maybe answered once we know more about the immunity, and maybe that will be better answered once these vaccine trials start coming out, and that will help. That will help. So anyway,
I think this is a great question. Should we assume that we will all get it?
I think this is an important question, actually, and I think it's related to the question of what was the point of shutting everything down in the first place. I think that a lot of us will eventually get this infection, and I think whether or not that's everyone or everyone's susceptible has a lot to do with whether or not a vaccine that works is forthcoming anytime soon. I think that you can imagine a future in which half the population doesn't get this infection if we have a vaccine by January and we continue to be good about social distancing. And I think you can imagine the alternative scenario where 80% of the population gets it and the death toll is staggering if we can't hold it together to maintain social distancing and using masks and being smart. And there is no success in the short term with a vaccine. And so I think it's a good question, and we will know the answer, but it'll take some time to figure that out.
How important is wearing a mask?
As I said earlier, you will get a multitude of different opinions. If you look at the WHO and what they've done, they've gone back and forth as to what they recommend with masks versus not. The CDC has done the same thing. And so I think it is a bit confusing for the general public, and I think it's confusing for us as health professionals as well. I think what you need to, or what we need to think about as a community and a population is what makes sense. And what we're trying to do, we know coronavirus by and large is spread via droplets. And what droplets are, they're little particles of moisture that come out of your nose and mouth when you sneeze, cough, and even talk. And we know with a lot of previous studies in influenza and so on and so forth that wearing a mask will decrease significantly droplet spread from an individual who is already ill. So we have data to support that. So I think it is only common sense that masks work. I think we do have some proof, and I think masks also have the potential of helping people get sick. It is a personal opinion, and you will get multiple other ones, but I think it's a very, very good idea, and I think it is still an important part of our armamentarium at trying to prevent illness from spreading and even getting it ourselves.
What is Torrance Memorial doing to prepare for the potential surge in the fall?
That's another very good question, and I think that what we have already accomplished, like I had said previously, with the significant amount of work that we put into place to prepare for the surge that we saw in March and April, we're already prepared for what may or may not, and I think that's an important distinction, be coming up when the viral season comes in the fall. So imagine everybody in the community is practicing social distancing, wearing masks, and washing their hands. that potentially could give us an incredibly mild viral season, one that we're actually not used to. Now, if those practices aren't performed, we could have a very difficult viral season, because remember, not only will we be dealing with coronavirus, we will also be having influenza, and that's the bigger fear that I think that most of us in infectious diseases, emergency departments, and probably the lab as well, given the number of tests that'll have to be done, are facing at this stage. And this coronavirus came at the tail end of influenza season, so we really didn't have to deal a lot with influenza, just coronavirus. But when we have to deal with multiple other respiratory viruses, that's going to be the difficult part. But again, at Torrance, I think we are prepared as well as we possibly can be to meet whatever challenges may be coming in the fall and the winter season.
And I would like to piggyback on that. Do we still feel that flu is the worst risk?
It's again a very, very interesting question. When you look at statistics on death rates and things like that from influenza versus coronavirus, certainly as more cases of coronaviruses are discovered, with death rates maybe not going up as much, the case fatality rate actually goes way down. And right now it's actually close to influenza at about 0.3 to 0.4%, where influenza is about 0.1%. So is influenza a worse illness? No, I don't think so. I think coronavirus is equally as bad. The difference between influenza and coronavirus is we have a vaccine for influenza. It's incredibly important that we all get vaccinated for influenza this season, so that we can at least attempt, because our vaccines are never perfect, but at least attempt to take influenza out of the equation when dealing with our viral season in the coming fall and winter.
I would just add one thing to that about influenza vaccination. So everyone knows someone, or perhaps it's happened to you yourself, where you got an influenza vaccine and then you got influenza anyway. But you're still alive, and probably that's because you got the influenza vaccine, at least in part. Protecting you from getting infected at all is only one way in which that vaccine works. It probably makes your disease less severe. And so even if you get the flu, it doesn't mean the flu vaccine was worthless. And it also may mean that you're less likely to spread it to the people you love. So that's a common refrain that you hear. I got the flu vaccine and I got sick anyway. Why did I even bother to do that? There is a good reason. You don't know what would have happened to you had you not.
And I'd like to piggyback on that from primary care. I hear the same thing every year. And I've seen all this fear about COVID, and I just wondered in the back of my mind, would we ever show the same fear for flu? Because they really are very similar in what they do. So if you're scared to death of COVID, get your flu shot, because you're fighting at least one of the elements that are going to be out there this fall.
Right. And if you don't like wearing a mask, you're really not going to like the ventilator.
All right. I have heard that the county is testing patients with or without symptoms, but at the drive-through sites, patients are swabbing their own mouths as opposed to doing nasopharyngeal swabs as is being done through the Torrance testing. Is there a significant difference?
I can take that. So in May, the tried and true sample is the nasopharyngeal swab. That's people call it the brain biopsy, you know, where you go all the way back and you touch the back of the throat through the nose. That was the preferred sample for in the beginning of this and up until May, when the CDC changed their recommendations and basically said that the anterior nary swab, the mid-turbinate swab, the oral pharyngeal swab, and the nasopharyngeal swab, there was no preference. And sometimes what swab you get depends on supply chain, what swab is available. The NP swabs can be a little bit more difficult to get. There have been some good studies on the anterior nary swabs for SARS-CoV-2 with the polyester, very inexpensive polyester swabs, which have been shown to be pretty much equivalent. with the oropharyngeal swabs, which is the throat, versus the nasopharyngeal swabs. Some say they're equivalent, some say the nasopharyngeal might be a little better. But in general, if it's early on, and if you're one of those phases of the disease that have a high viral load, they're all going to be pretty good. I must say that when winter comes and we're dealing with influenza, everyone's going to have to go back to the nasopharyngeal swab, because when we do the multiviral panels, the BioFire, that's just nasopharyngeal. So for screening, I would say it's fine if you get an oropharyngeal swab. It's fine if you get an anterior self-collect nares swab. The self-collects have been shown to be just as good as the provider collects with the anterior nares. People sometimes are even more aggressive with their own self getting a test. So I would say that whatever facility you're going to, what their procedure is probably fine. But we may be back to, if you're symptomatic in the fall and there's influenza involved, then we're going to be back probably to the nasopharyngeal swabs again.
Do we know what the reason is why some people have symptoms of COVID and others don't?
No. Would love to give you an answer, but we just don't know.
And I'll piggyback a little bit on that. Do we have a time frame? Do we feel like in a year we'll have the information? Is this just so confounding at this point we don't see an end in sight?
I think, boy, that's a tough question, I think. You know, I don't, I think we'll see an end. I truly think we'll see an end. And I think that end will come with a vaccine. Up until that point, I think it's going to be a variable ride, if you will. And I think, again, like to Dr. Kunesh's point earlier, you know, we've only been doing this for 6 months. I think we have learned a tremendous amount in a 6-month period of time, probably more than we've learned about other illnesses in a similar time frame. We will continue to learn. We will continue to update all of our stuff, but I don't see COVID-19 going away anytime soon. I think the vaccine will be when that happens. And a vaccine coming towards the end of the year, I think, is way overly optimistic. Yes. I think all of us here at this table realize how difficult it is to make a vaccine safe, to get appropriate testing, to find out that it's making the correct antibodies and so on. So I think we're looking for quite a bit longer than just the end of the year.
How vulnerable are those with AFib or valve disease?
So I think I would say that with respect to the infection in particular, you're probably not any more vulnerable with those particular diseases than you are with many other diseases. I think the more important question is how strong is the heart muscle function and how well can you accommodate the degree of stress that the virus is going to present to you if you do get seriously ill with it. So I think it's more about something like your ejection fraction and your other organ systems like your kidneys and so forth, whether or not they can help your lungs cope with what's going on. But, you know, I think that the problem is that those problems don't exist in isolation typically. So if you have atrial fibrillation, you're much more likely to have a whole host of other problems that have been identified as increasing your risk of doing poorly. So that's how I would answer that question.
Is it safe to go now for a mammogram or a 6-month eye exam?
I would say absolutely. I think that with the coronavirus and what we've done, and with knowledge of what we've collected in regards to keeping people safe in offices, as you alluded to, Dr. Miller, before, I think it's very safe. And I do think it's important. We've said up here, you know, a few separate times that maintaining your health and your screening that can keep you healthy over time is extremely important. And by putting those things off, you're just putting yourself at risk. And I think even more risk than potentially developing coronavirus by going to your eye doctor's office, your primary care doctor's office, or the emergency department.
Do all COVID patients have damage to the lungs?
So the answer to that question is yes, there are changes in everybody that at least is admitted. I think it becomes a little bit more difficult for those with mild cases that we're not doing CT scans on, although there are some very good studies out of Italy that have varying degrees of CAT scan changes, and we do see changes with just about everybody who is infected with COVID. I think the real question is, do these changes improve? So far, they appear as if they do. People who have underlying lung disease may be certainly at more risk of having a decreased respiratory function after COVID, but for the vast majority, it does appear as if people get better, and if there is any lasting damage, it appears subclinical.
I have been impressed by how long people are hospitalized when they get sick. Is that a product of the fact we didn't know how to treat them and now we have better ideas, or is this usually always going to end up being a prolonged hospitalization?
I will tell you, having cared for several hundred COVID patients at this point, for the most part, whether young or old, it does appear to be a more prolonged hospitalization. There is something different about coronavirus than many of the other viruses that we have had to treat. I think there is at least a component of not having had some effective therapy for coronavirus, and there certainly is a tremendous amount of interest in therapeutics going forward with all of this, and several randomized clinical trials of a multitude of different drugs. But we're still dealing with a virus, and viruses are difficult little beasts. And so this one in particular does seem to, when it allows or gets to a point where somebody has to be hospitalized, they are sick, and they stay hospitalized for a while, I just have to say.
Is it safe to go to the dentist?
I think that depends on who your dentist is. No. Yeah, I don't see any reason why you should not go and see your dentist as long as you're not having symptoms, so you don't get anybody else sick. Most dental offices have very elaborate protocols to make sure that nobody that's working there is a risk to infect any of the patients that are being seen. So yes, if your dentist feels that it's as safe as any of the other things we're talking about.
All right, I think we're going to close for this evening. We want to thank everybody that joined us on our very first attempt at Facebook Live. I think it went well, and we'll work on where it didn't go well. I want to thank again our panel that took their time and gave us some very thoughtful answers. And we want to thank everyone out there for watching. Please remember, if you take nothing else from this evening, remember, wash your hands multiple times. Please wear a mask. I know none of us like them. If you wear glasses, you fog your glasses and you can't breathe and all of that. But it does seem like that is one easy way that we can try to control this until we can understand it better. And then the social distancing, the 6 feet between people, does seem to have some reliability. And again, another relatively easy way to try to say, let's figure this out and be safe. So great job for everybody.